Hello, my name is Fraser. I'm a physician at Flying Horse Medical Center, and I'm joined today with Dr. Wilkey, who's also our psychiatrist, who also works out at Cedar Springs, and then Jeremy Feranti, who is one of our local business owners. And today we're going to get a perspective on, from the public side and the medical side and the mental health side in relation to some pretty controversial topics, specifically associated with COVID-19, COVID-19's effect on our community, and COVID-19 effects on mental health in the community. So I would like to start basically by talking about our shutdown and whether I think it was a good idea, and do I think a shutdown is a good idea again. So the first topic, do I think the shutdown at the beginning was a good idea? Absolutely I do. And the reason I think it was a good idea was mainly because with the information that we had at the time, we did the best we could with what we had, and we were initially looking at numbers of potentially millions of people dead. And when you're looking at millions of people dead, you have to do some very drastic things. Now, with that being aside, do I think a shutdown at this point is a good idea, or even in the near future? With the information that we now have, I think that is a really bad idea. And the reasons being, in relation to the shutdown, I think is a bad idea, is that what we're not talking about in relation to the shutdown is what type of death rates we were actually looking at, not associated with COVID-19, that were higher than the average. Meaning, if you take the same number of people who passed away or died last year in 2019 during this time, to the number of people who have died this year, the number is significantly higher, even when adjusted for COVID-19. So now you're looking at those numbers. Are those numbers so much higher because we're missing people who have had COVID-19 and are dying from COVID-19? I really don't think so, because everybody who passes away or goes to the hospital is now being tested for COVID-19. So initially, back in March, we might have missed a couple hundred, maybe even a couple thousand, but those numbers, statistically speaking, are pretty small. Those numbers that we're looking at now are more likely associated with things in relation to the mental health and the medical community that are being missed, such as the increased rate of alcohol abuse, the increased rate of suicides, the increased rate of people not getting taken care of for their medical conditions because they're just too afraid to go out and be seen. The increased rate of substance abuse, the increased rate of domestic violence. All these factors have had big sociological impacts that we're really not talking about. And it was a shutdown where we might save several thousand to possibly hundreds of thousand people, really worth the amount that we're sacrificing in relation to these other disease processes that are not being talked about. And so we're going to talk about that today a little bit, not only from the mental health side, but from the business side, as well as from the medical side. And trust me, I took an oath, I try to save as many lives as possible. So we're going to talk a little bit about that. The other thing I would like to talk about is the death rate. And I kind of touched a little bit about that in relation to the shutdown. We have to realize, and these are just horrible things to think about, but they're things we have to talk about. There is 2.8 million people who die every year. Every year, 2.8 million people die. In this country alone. We're not talking globally, we're just talking about in the United States. And we're talking right now about, from the CDC, so this was updated September 4th to 2020 on the CDC website. Now obviously on the Johns Hopkins website, it was closer to the upper 180s during that time. But just for the CDC website, and we have to realize it takes up to 8 weeks to fully get death numbers from death certificates registered at the CDC. And so that's why these numbers are slightly skewed. But if we're looking at death rates, the people who have died at 169,044 as of September 4th, between the ages of 65 and 85 account for 79% of the deaths. That is a very high number in relation to our elderly, and we absolutely need to protect the elderly in relation to the death rate, in relation to COVID-19. Now, if we extrapolate that even further, down to 55 to 85, that accounts for 92% of the people who died. That is a huge percentage. We are shutting down our country and shutting down our economy for a vast majority of the people who are currently out of our workforce. So
that was 55? Yeah.
55 now. It was 92%. Yeah. So that is a huge huge number that we have not been addressing, and we need to talk. Now, and those people who are 55 to 65, that accounts for that extra high percentage, frequently have significant comorbid factors. So people with diabetes, high blood pressure, vascular disease. So we have to take a look at those people and say, okay, we need to take higher precautions for you, but that does not mean that we need to shut the entire country down or the state down. Now, if we have high rates in a certain local area, yes, we probably should have some degree of a smaller shutdown for a shorter period of time in a very localized, and I do mean by down to city blocks to cities, not even to counties, but not states. So those death rates, those are actual numbers from the CDC website, and give or take whether we believe the CDC right now, those are the numbers that we are all working with and are fairly accurate in relation to what we're talking about. And that brings me to the next topic is that we're going to be talking about recently stuff in the news. So what we really are trying to do here is have a civil discussion in relation to things that are very difficult to talk about and be completely apolitical. Look at the numbers. What is the right thing to do for people? And not go on the left, not go on the right, and I'm not pointing to either one of these people in relation to that, just in general, that's my left hand, that's my right hand. So that brings me to the topic of the CDC, where recently in the news is reported that only 6% of the people actually died of COVID-19. And that is just poor reporting. I mean, I hate to say it is absolutely horrible reporting.
And by that you mean a 6% death rate?
A 6% death rate from the COVID-19. From the 6% of the people reported.
6% of the COVID fatality population
died from
only COVID. Underlying issue of their fatality
was COVID.
Was COVID.
Was just what was reported.
Yeah.
However, that again is just poor reporting, because what they're missing is what does COVID frequently cause that actually causes death? It causes pneumonia. And so people are putting down pneumonia as their death, which is true. But what caused that pneumonia? Well, the COVID is what caused that pneumonia. So they're getting rid of that in that reporting. So the people actually, these numbers are actual, what people are dying. Now, are we missing a couple hundred, like people being, for example, Colorado is a great example. Mainly because we live in Colorado, where people were being reported twice. They get tested and they get tested again, and then their numbers would be reported again. Now, Colorado actually adjusted their numbers and came back and took those double reportings back, and so those numbers have been adjusted in relation to COVID-19, in relation to illness, and then some. And if we're talking about people who died in car accidents who have COVID, the likelihood that the COVID caused them to be so sick to get in an accident, die, probably pretty small. But we're talking in the hundreds, maybe even the thousands. But when you're talking about the numbers that we're talking about, to the hundreds of thousands, even to the millions, those numbers are really fairly inconsequential. So, and I truly believe they even out on the ones that we missed early on because we weren't testing. So, yes, those people have died. Yes, we've had probably close to 180,000 dead. That is a horrible number. It is not something that we should take lightly, and we don't, as a medical community, do take that lightly. But in the same token, we also have to realize 2.8 million people die every year in this country. So that comes to that was reporting. I'm going to say on the more the right side. See, we didn't need to shut down. Only 6% really died of what actually was reported. To the other side, where on the Sturgis reporting, there was close to 266,796 people who got COVID-19, costing a medical bill of $12.2 billion. So that's the far left kind of reporting. And I'm going to say that's a bunch of bumpkins too. So far, there's only been approximately 270 people confirmed. So and I know for a fact, there's some people who aren't reporting it because some of them are my patients. And I didn't test them, but we know they have it. They're now reporting. So let's double it. Let's even triple it. So let's go to 1,000. 1,000 is still far less than 266,000, right?
And the cost behind it.
And the cost. So the cost of the 12.2 billion. That's an excellent point. Let's talk about that real quick. That is assuming that every single one of those people, that 266,796 people, were all hospitalized, and all of them had a bill of a minimum of $46,000.
Yeah, that was I think that if we're going to do this, I think an important thing to sort of cloverleaf or back around to is the incentive, or what was sort of like baked into the CARES Act for people and hospitals.
Yeah, we'll come back to that. Let me finish up what we're talking
What
about.
what they make as an adder or a multiplier for COVID-coded patients.
Yeah.
It's a big number, 25% or something.
Yeah, it's pretty, and we can, that's
So,
a topic for a whole, that's a
I'm
whole
sure it's
other
a whole other
discussion.
thing, but
Yeah.
very
So-
important.
The next and last topic I want to talk about are masks. Masks are a huge topic on both sides. So we're going to get into the masks portion a little bit, but let me just give you actual information, true 100% information. I just did a research PubMed search earlier today. Is there any good population study for using a population wearing masks where it shows a decrease in infection of any disease process? The answer is no. It does not exist. Now, are there very good studies out there that demonstrate that masks in a clinical setting, in a setting where in a lab, that masks work at decreasing spread of disease processes, viruses, bacteria? Absolutely, it does work. So let's look at a couple of different things in relation to the masks, and then we're going to open this up to a discussion, and we're going to kind of go backwards, if you will. So first we have to realize what we're talking about in relation to masks and why masks actually do work. Do I think masks work? I do think they work. I am a proponent for masks. I think we should be wearing masks in public settings. I truly do believe that we need to be doing that. When we're talking about the COVID-19 virus and it being aerosolized, what that is actually talking about is droplets leaving our mouth, liquid droplets, where the virus is actually in those droplets, leaving our mouth and going and landing on other mucosal membranes of another person, whether that be your eyes, your nose, your mouth. That's why people are wearing goggles, etc. So what does the mask do? The mask decreases the amount of those droplets leaving and going into the actual air. Okay, so will it still get out through the mask? Absolutely. Even if you have the vents, if you have the vents out here, no mask is 100% unless you're in a full suit. Not even the N95 is 100%. You can get a droplet on the N95, the virus can still go all the way through an N95, and you can inhale that and you can get it. Now, another thing that the mask does is it decreases that aerosolization. So those droplets stay on your mask, they don't go out. The other studies that we need to be looking at are more in relation to these masks, is not actually associated with masks specifically, but we're talking about viral load exposure. Several studies have shown that people have had a large viral load exposure are much more likely to have a more severe illness and have a higher likelihood of dying. Where if you have a much lower viral load exposure, you have much less likely of having a severe disease process and are able to recover generally more quickly.
Now, what about the bioaccumulative load exposure, like over the span of a lifetime, right?
So let's get into that. Let me finish it real quick. So in relation to the masks, do the masks work? I truly believe they work. We don't have good data yet because, again, data takes time to collect. Data takes time to report, and I can tell you right now we're going to have population studies on masks and whether it decreases infection rates probably at the end of 2021 and into 2022 once all that data is collected. But it's going to take that long to get all that information. It doesn't happen overnight. So that is one of the biggest issues that is very controversial right now is, do masks work? Personally, I think they work. Do I have any population studies that work? No. But I would like to put out a number there, and again, I'm a numbers guy. I want you to show me the evidence kind of thing. That's why we're doing this. Is before the mask mandate, there was roughly 1,000 people dying in the United States every day. 1,000 people. 10 days after most states put in mask mandates, that number dropped to 300. But it was 10 days later. which shows me that there was a significant drop in death rate when that went over. What was different between that time frame and that drop, that very significant drop in death? The only thing I can find, and I am open, as Jeremy has discovered, to being told I'm wrong, and I am open to suggestions and research and numbers. You just have to show me. And like I said, I'm open to it. But the only thing that I could find that was different was the mask mandate. So, does that matter? So, now we're going to open it up to our panel. We're going to have that open discussion. Let's start with the mask issue. Who would like to go first? Who has some questions, statements? What do we want to do?
Yeah, so let's talk about the masks a little bit in regard to being in a medical setting. I work at a hospital in the mornings, and we're around people that are homeless, people that are alcoholics, people that have drug problems, people that might be at much higher risk of having infections. And interestingly, we haven't seen a lot of COVID infections in the hospital. That's an odd fact, but it isn't evidence that you shouldn't be very concerned. You should obviously be concerned, and the rule is you have to use a mask at work. It makes sense in certain settings where you're at high risk and there's high levels of exposure. A grocery store makes sense because you're in a public setting where you're passing all kinds of strangers that you don't know. And there's no cost to wearing a mask. There's very low risk to wearing a mask. We've talked about that. So my point in saying it is, even though we've seen very low rates, I don't think, and that's what I think people say. They say, well, my anecdotal experience is I don't know anybody that's gotten COVID, or I don't know anybody that's died of COVID. And I'm around a lot of people that, on a regular basis that theoretically should be sick, and since I'm not seeing it, I'm going to assume that maybe this is being overblown. That is anecdotal reasoning, but I think it's poor reasoning.
So you're saying you think it's being overblown, COVID-19 is being overblown, or do you think?
I'm saying when people use anecdotal reasoning, that they don't know anybody who has had the experience or they're in environments where there might be high levels of people that should have infections that don't, they say to themselves, this is being overblown. But I think that's poor reasoning.
I see what you're saying. Yes.
I think the mask evidence that you've given us is accurate, and I think that we should all take those precautions for a societal good for that reason, regardless of my personal experience telling me something different.
Well, and let's look at some of that brings up a great point. You actually mentioned it, and I've had this discussion with several patients who say they think it's a hoax. They think, and I can tell you right now, I have a bunch of buddies in Arizona, Phoenix, New York City, that this is not a hoax. Just FYI, not a hoax. Several of my friends who are gerontologists taking care of the elderly, multiple patients dying, I mean, they're burnt out. But anytime we're looking at any treatment or possible disease-modifying agent, or whether it's a medication or whatever, we always do a risk-benefit analysis, right? Does the risk outweigh the benefit, or does the benefit outweigh the risk? And then that's how we make a medical decision. So let's talk about the risk. What is the risk truly of wearing a mask besides long and short risk is pretty low. Okay, I mean, you have surgeons wearing masks all day. We've been doing it for, I'm not a surgeon, but we as a medical community have been wearing masks for decades, okay? And we've demonstrated that it decreases infections, okay? So the risk is pretty small. There is an inconvenience. I mean, the biggest ones I hear is I don't like it. It causes my glasses to fog up. No one I have talked to, and if someone can give me a good reason, I'm all ears. I'm anxious when I wear it. That's one of the common ones, and we're going to get into the anxiety component of that. But I haven't heard a good reason why someone shouldn't wear a mask. Now, the one that I would say personally, just from my military experience, is, and also on the state website that states what are good reasons to write a script for someone not to wear a mask, is a sensory disorder in the children. So the only one we've actually written for, we've only written one, was a child with autism. And they had a sensory disorder, and they could not wear the mask, and they were over the age of 10. The other reason from the state of Colorado is if they have no ears, which I'm going to have a problem with, because even if you have no ears, which usually happens from somebody who has been in a blast or a deformity from birth or something like that, there's plenty of the masks that wrap around all the way, not a handkerchief, an actual mask, and I have them. I work out in them, where they Velcro on the back of the head. So I even disagree with that aspect. Even if you don't have yours, you should be wearing a mask. The only other one that I would agree that we should not have them wear a mask is if someone was in a PTSD situation that was waterboarded or something like that. You don't want someone wearing a mask having flashbacks in the middle of a store. It's not a great idea. That would be one of the only ones that I would say, yeah, you probably should not be wearing a mask. So those are our risks, right? Risk, pretty small, very small population of people who should not be wearing them. Benefit, keeping our businesses open, keeping things moving forward, getting my kids back in school, keeping sports moving along, which helps with the mental health component, which is a big deal, which we're going to get into in just a little bit. But that benefit, even if, let's take everything aside and just say the masks help 5%. 5% of the numbers that we're talking about keeps our businesses open. We know already, just based on the numbers I've said, that it's more than 5% effective. But say it is only 5% effective, and we decrease those numbers by just 5%. That 5% is enough to keep our businesses open, right? So the risk-benefit analysis in relation to my opinion, and in relation to some of the studies, wear a mask. And it's that simple, but that is from the medical perspective.
So, I mean, I could give you the like human perspective, I think, at least from my position,
Yeah, please.
my standpoint is, right? So there are no guarantees right now on a vaccine. Sorry, there's not. We are on the pathway to herd immunity, whether or not people are willing to accept that or not, we are. As I understand, there's been 7 strains of coronavirus known to man, and there has never been out of any of those viruses a vaccine, a viable vaccine to cure any of those coronaviruses. So we could have it in a year, we could have it in 2 years, we could have it in 3 years, we could have it, sort of whenever. So, I mean, there's a certain part of me that agrees, yes, but then there's another component of me that says, hey, we live in this world where there's no sort of like guarantees for tomorrow. And germs are a part of life. Germs and bacteria are part of life. They're part of the world that we live in. As sad and as it sounds, we may or may not get a viable vaccine or a viable cure, and this is sort of going to have to work its way through the population, to a certain extent. Maybe I don't know this for certain, but maybe either of you can elaborate or add to this too, right? Is that it's my understanding that when you wear a mask or whatever and you have like a viral load inside of your body, that when you start to tax your respiratory system and your organs and etc. from wearing a mask, you can create or like hyperdrive the viral load in your body, and you can sort of pull carcinogens and toxins out of your body and introduce them into circulation, and that can make you ill. So I mean, I don't know.
So with that mentality, though, you're talking. I see what you're trying to say, but with that mentality, if you're saying that, then every single surgeon, every single lab technician, every single person in a controlled environment that wears a mask all day should be fairly ill, because you're right, viruses are everywhere and you're loading that system all the time.
Right.
So
you still have a lot of touch and exposure in the medical environment. When you're in a cafeteria, you're passing people in hallways, you're touching doorknobs.
So I'd like to go back to history too. I'm a big history buff, especially when it comes back to medical stuff. So let's touch on that just for a second. It's still in relation to the masks, but look, if we look back at all the history, all the pandemics in recorded history, every single pandemic, 1918 Spanish flu, the one in, I think it was 56, 83, and even the one in 2006, the H1N1, 2009-10. Those last 18 months. Every single pandemic has lasted 18 months. Now, whether we've reached herd immunity, whether we've reached, and they used all sorts of different trials and stuff back then too, not a lot of it worked. but it lasts 18 months. So to think that we're going to be going on this for years and years and years. Now, there's a bunch of different doctors and physicians who are saying, well, this might be different than the other ones. I'm sure they were saying that about the Spanish flu as well. Will we ever completely get rid of it? No, but that's where, Spanish flu then led to now our flu vaccine. That's kind of the progression of things. And it's a guess and we miss. And I know you're prior military. I know for a fact you've had one of the coronavirus vaccines way back when. I know I have had one. Does it work? Probably not. Is the one now going to work? They're actually using a completely different modality than current viral vaccines are working. Just yesterday, one of the major companies that are producing, I don't know if you guys saw this, producing the vaccine had to stop their trial because of major
they're on their second cancellation.
Yeah, second, because of major
complications. Yeah.
So I agree with you. I think it is going to work through our system. I truly believe between April and June of next year, this is going to peter out, but it's going to be April or June of next year. It's not going to be, as I've had 4 people tell me this week, the day after the election. Because again, the virus does not.
I don't believe that.
The virus is not political. India, who's having the highest rates of cases and deaths right now than anywhere else in the world, does not care about our politics. Brazil does not care about our politics. They don't care, and those are still real people who are getting very sick and dying. So it's not going to end at the end of our election cycle because no one, to be honest, the world doesn't care about our elections. So it's something that we need to be aware of. So I hear what you're saying in relation to that about putting your viral load, but if you're already sick and you already have COVID-19 and you're wearing a mask and you're going out in the public, shame on you as it is. So, I'll be honest in relation to that. If you're talking about just in general toxins, carcinogens, viruses, the people who wear masks all the time, and it's not just medical personnel who do that all the time. You're also talking about painters, right? They wear it for long,
construction.
Masks are huge.
They're huge.
And then that population in and of itself would be very sick all the time as well. Yeah. So I've heard that argument before, and I'm sorry, I don't believe in that. And it's a belief. I haven't seen the evidence that supports that.
Yeah. Huh.
So, all right, let's kind of jump. We're going to jump a couple of topics back up, and let's talk more about the shutdown. Good, bad, or indifferent. What do you think?
The shutdown.
And so specifically, I want to point out that we're talking about the shutdown in Colorado.
Yeah, so do you want to?
Because if you're talking about the shutdown, like in New Jersey, heck, they're opening restaurants next week for the first time ever. In Colorado, we opened restaurants back at the end of the day. Now we open them, close them, open them, close them, open them again, and now we just have limited times and limited number. But we've stayed open pretty much since June.
So what I can say about the shutdown is I think initially when the order to shut down everything and just kind of like lock it down and just do like a smell check of like what's going on, like pause, time out world, let's see kind of what's going on, and then let's like evaluate the situation and delve into like the ramifications of bad choices and bad decisions and develop some sort of like strategy. So I think initially the let's shut down businesses and halt everyone and just like freeze the world. I think that was, from a small business standpoint, the right thing to do. As upsetting and as frustrating as it led me to believe.
And I'm a small business owner too. It affected us in the medical world and small business. It affected. It affected everyone across the world. Across.
We have a lot of touches. We have a lot of touches. So I'm an entrepreneur by trade, writer by nature. So I have my hands in probably 15 or so organizations. I'm a job creator, right? So you run into a scenario where you sort of like lose income, right? You're starved of income. Not only that, too, I own a bunch of commercial properties and residential properties and real estate properties. You run into people who aren't working and they need to pay rent. You run into like storefront owners who need to pay rent, and you have like leasing agreements with them.
Oh, yeah.
And that was like a big deal when you shut everything down, because immediately people, worry, like, oh my goodness, like I'm a small business owner, I own this storefront, and I'm not gonna make any money. How am I gonna feed my employees? How am I gonna like make ends meet and like take care of my family at home? I have no money coming. So initially the pause and like the money in to lock it down, I think there was a big scare that was involved in that, at least from what I
Well,
see.
and we're showing, demonstrating not only just the scare and the money. I mean, we're talking trillions of dollars lost.
Yeah.
Did we do that?
Huge things.
Right. I mean, again, hindsight is 20/20, right? So at the time, do I think it was the right thing? I do. And do I think there are huge ramifications? Absolutely.
Yeah. Then I think we going to full open. That was sort of like a calculated risk. Do you not? Because you just really don't know. I think once COVID sort of like showed its rear, like what the consequences of that type of attitude or behavior were. Once that showed itself, shutting it back down was the right thing to do again, and then developing a more responsible response. So coming back into it now, this sort of like slow open, I get it. I'm grateful that people are getting back to work and they're getting back to like some semblance of normalcy. There's like some weird things that like fall into like opening that I don't really understand, right? And that are somewhat confusing to me. Like, why set a curfew on like a restaurant or like a place that serves food for like 10 o'clock? As if like COVID comes out later and it
And I think that issue just came more from the fact that people just do dumber things. I mean, we've seen that. I mean, one way or the other. I mean, whether you, and I'm really not trying to get on the political side. I'm really trying to stay political, which is very difficult. But I mean, take a look at the protests, right? Right. Majority of them during the day are very peaceful.
Okay.
And then they turn violent at night. I mean, we've seen, and I've said this many times to many different people in different walks of life, individuals are incredibly intelligent. Mobs of people are incredibly stupid.
Mm-hmm.
And so,
That's a fair assessment.
I mean, you've seen that in the military as well. I mean, you get certain aspects. Anyway, that's a whole other topic another day. But I think that's where that came in, is just to kind of decrease that risk. So I agree. I mean, certain things are, you can explain away a whole bunch of stuff. But one of the things that I was concerned about with the shutdown, and that was I think it was the right thing to do initially, but some of the bad outcomes that came from that is that mental health component. And I mean, I know from my aspect, I mean, I've had some of the strongest people I know that are so anxious, and I've had to put them on antidepressants. And they were rocks, and they have they're financially stable. Some of them are actually making more money right now because they're in businesses that are doing well. We're lucky to be in a community that allows us to financially grow. Or a lot of communities in the country are not there, right? So I've had to myself diagnose a ton more depression and anxiety and take care of that. I mean, you're actually seeing it in the hospital setting too. Have you seen anything change? I mean, increased suicides. One of the rocks in Flying Horse just committed suicide the other day. I won't mention names. It wasn't a patient, but I mean, that is a real issue. What do you think?
So statistics on suicide are tricky right now because, as you said, that takes a while to get those. In Colorado's high, regardless. All the Rocky Mountain states have much higher rates of suicide than other parts of the country. And El Paso County has higher rates than everywhere else in Colorado. So we know, we're very familiar with that here. Mm-hmm. But if you generalize out and take that issue out of the topic, the studies have shown that their anxiety levels and depression levels are 2 times to 2.5 times as high as the general population a year ago. That's significant. And you were talking earlier about losing your business or shutting down business for a while. I think we underestimate what it means to be socially isolated or to have your financial health threatened. Mm-hmm. It would be abnormal not to feel anxious in those scenarios. And those are things that essentially everybody's been touched by, everybody. When you start, grandparents can't see their grandkids, or you can't hang out with your friends, or you can't you have to break all your routines. You can't go to the gym. All these things that happen hurt our mental health. And there's no question that that's one of the topics that we have to talk about a lot more in sessions when I'm talking to patients now. But you talk with everybody you talk to, it's the same conversation. Those have been impacts on all of us. And I really feel horribly that we shut down the economy as long as we did, the impact. I wasn't touched by that. But the people that are, I can't imagine the anxiety levels that come with that. So.
And we're not talking about just the rich too, right?
No. I'm talking about.
There's still millions of people that, and not only that, there's industries that will never come back. There's storefronts.
And there's going to be a ripple effect moving forward here. You know, these dominoes are still falling. So it's very concerning to me. And I don't want to see it shut down again, because I don't want to see people's mental health and financial health take a hit. I mean, we're human beings, and I agree with you. These are things that we have to learn to deal with. And isolating and trying to create bubbles all around us when it's really the elderly who are paying the highest price. And these are the people that should be seeking shelter and that we should be seeking to protect. The rest of us are going to have to take our lumps and move forward. And it's horrible when people die. We don't know who it is. It seems rather random at times who gets hit. But it is part of life. I agree with you there. And I do think we underestimate what it means to be human and continue to feel alive and connected and have meaning and purpose and routine. To minimize that, I think that's a big mistake. And to only talk about deaths and the R factor, it's like, yeah, that's important, I get it. But now that we know that this isn't a wildfire spreading through and dropping 1 in 4, I think we need to rethink what we're doing here. That would be my take on that.
Mm-hmm. And we do need to reiterate that the people who die from this, it is horrible. It has effects. It has effects on the economy as well. It also has effects on the mental health of the people who are still around, dealing with the after effects of the people who die.
Well, we're not hearing about this. We're not hearing about, but right now, unfortunately, COVID is stealing all the oxygen in the room. Mm-hmm. We're not hearing about all of these other deaths that are associated with it, like the mental health deaths and the suicide rates. I can tell you that there are the likelihood of exponential suicide rates and drug overdoses, right? And just raging scenarios and violence in the household and in the community. I mean, it's an elevated cause and effect thing. It seems to be COVID is stealing all the oxygen and robbing that conversation that needs to be had, and very little attention is being paid to that. And I think that's sort of a disservice, but that's my opinion. But I think you put a lot of credence in and touched on some very important.
So I want to kind of bring up another controversial issue similar to this topic, especially in relation to deaths. And you're saying that COVID is taking a lot of the oxygen out of the room. Let's talk just briefly for a second, because you're saying, let's let it run its course through, the people who are 0 to 55, much less likely rate and cause of death. Let's get some herd immunity going. But what people aren't talking about too, in relation to this aspect, again, kind of trying to be apolitical, but look at, okay, we're saying this, okay, let's do that. What we're not talking about is the post effects, the post-COVID syndromes, and what that has on the individual, and what that has on the financial.
What that looks like.
We don't. And what that looks on the financial aspect too. So if you're taking a good majority of your population, and I have a very small number, so my N number is very small in relation to these huge numbers, but I have people who are very, very ill with COVID-19. Luckily, thank God, none of my patients have died, and I've had pretty old patients with COVID-19, and that's a whole other topic about how to avoid dying from COVID-19 in relation to your comorbid factors, in relation to doing things healthy, exercise, and things of that nature. But I have several patients who have this post-COVID syndrome where they have a problem walking to the mailbox, and they were fairly healthy to begin with.
That'll be a long term.
Well, who knows? It might be. They were sick. The couple I'm thinking about were sick 3 months ago, right? And they still have a problem walking down the mailbox. They're healthy people. They were part of the community that were, out in the community and contributing to society. And now there's several of those that are now looking to vascular disease. So are we going to look at a decreased death or a decreased life expectancy in 10 years? Are we going to be looking at the cardiovascular effects? What does that, I mean?
Yeah, the data, I don't think the data is there to be
It's
able to
not.
make a
But I mean, what we're saying,
hypothesis on
not cavalier, obviously we're making a very educated discussion about this, like, hey, let's, 92% of the people who are dying are 55 and older, let's protect them, take our lumps where we can get it, but what we're not talking about is, okay, we're going to take our lumps, but what does that lump look like in a year and a half?
And we don't know, right?
Yeah.
So it's impossible to make a decision on the things you don't know. And you can be cautious about it, but you have to move forward until you have a compelling reason to alter course for all the other suffering that goes on.
Yeah.
I just want to make sure we're talking about both sides of
I
that
know it's
aspect.
important. No, it's real. We don't know what it is.
Right.
And everybody has a story or two. And the media, I don't think the media helps us here. I think the media is often there to kind of inflame passions and sell yourself and make you a constituency for a voting bloc. They're not really there to educate you. And that bothers me a great deal.
Yeah.
So we all hear about these
Totally.
stories that inflame us or that make us very fearful, but it doesn't help us make informed decisions. And that's that anecdotal reasoning thing. It's like, well, here's a case study. Well, case studies shouldn't become the reason we make policy.
Yeah. Well, so I mean, and there's still a lot to be learned
Oh, yeah.
when it comes to COVID, right? At least my take on it and what like I understood, just the evolution of COVID and the migration from it specifically being sort of like a respiratory illness, droplet illness. Now it's sort of morphed into more stuff too, right? So
Vascular and
yeah, the
neurologic. And
we had this discussion sort of off onto another tangent, and I hate to like steer it there, but there was a discussion that we had, and I pointed you in the direction, and maybe you saw that too. The Bradykin analysis that just came out, and that's where in the medical field, quantum analysis and quantum computing is sort of being introduced recently, right? So quantum just emerged last year, like November, in the medical and health sciences field, right? So now you have these large archive collections of all of these research studies and patient studies and all these medical surveys, right? They're being conducted on a global scale, and all these inputs that get stuff, stovepiped into like Watson at like UMass, right? And you can sort of create like an analysis of an illness and an ailment, and you can like basically get determination or basically get a diagnosis for whatever. So what we were told initially from the COVID, at least I understood, was that it was a respiratory thing. It entered the body through ACE2, where those receptors exist primarily in the lungs and in the nose, right? Those are where your ACE2 receptors are, and then it sort of attaches itself, comes across a bridge in a cell, and then it becomes to eat the cells and mutate inside the cells. Well, the Bradykin said, now that we've had COVID in America and we have all of these new studies and surveys and data that's coming out, let's collect all of that hospital and patient data and all of the survey data and plug it into a supercomputer and let the computer tell us what we don't know about COVID or tell us where it may or may not be, because obviously you have the quantum analysis you have. It can be both on or off,
quantum analysis
Yeah,
is
it
above
can be
one.
yeah.
It's got a third digit.
It can be the third degree, right, and that whatever. So the Bradykin says SARS can enter the body or attacks any of the ACE2 receptors, right? Not just specifically the ones that are in your nose or in your lungs. It can attack the ACE2 receptors in your kidneys or in your liver or in like your digestive tract. Any organ in your body has ACE2 receptors, right? So what that led me to believe when I read the Bradykin analysis is all right, well, if Bradykin's real and this supercomputer says so, and it's conducting all of these calculations by gathering hundreds of data points that would take years in old computing to do a calculation on it. It can come up with that in like 10 days or something. If it's telling me that all of these entry points exist in my human body, that we need to look well beyond the mask, right? And well beyond sort of like what COVID is, because it tells me like, if I drink something, right, and COVID's in a liquid, and it's in my stomach now, it's gonna like enter, the entry point can be some sort of like, somewhere in my digestive tract. It can enter in my liver, it can enter into my kidney, it can enter into any other organ in your body. It can come into your, you know, through your heart, coming in through like a cut or something, right? So that sort of like really piqued my interest and sort of changed and reshaped and sort of like bent what I thought that I knew about COVID. And I was like, wow, this is so much bigger, because you start thinking about like food supply and beverage supply and like things that you touch and things that you can't see. You can see a mask, you can see a person, you can see that distance. You can't see like what's on your food or what's in your cup, right? Or what's in your ice or what's in your water, right? We're testing water to see where the COVID's at in society. That's like a recent thing, right?
It's actually been since about May or June.
Yeah, we're testing sewage, right?
Yeah.
And we know that it's in the sewage, and then we are reliant on this like sewage processing, like reprocessing and sanitizing process to get out all of these carcinogens and things in there. But it raises a lot more questions, and it like leads you to think, man, there's just so much more that we don't know about it, you know?
Yeah.
So sorry to go off on that, but
Yeah,
that's,
I mean, and that's an interesting topic. That's more about
That's
the
weird.
biophysiology, pathophysiology of the COVID, and leading into more of like, okay, those are topics that we can look at for sure in relation to making a very good.
I think the point was that it's still moving and we don't.
Oh, it's a moving
know.
target for sure,
So,
but it's going to
So
allow
much
us to
moving.
make more educated guesstimates on what we need to be doing for specifically looking at, you know, this post-COVID syndrome.
Right, the miss, right, so what if the big miss though is that, all right, so we've got the respiratory component of this illness, we got that on lockdown, that's great. But the long-term thing is, say, the assimilation point or the rejection or the time it takes to like enter through ACE2 through an organ is like this much longer process. It's not like an accelerated like 10-day.
It could be like herpes zoster. It comes back 30 years later and
Right.
you have
Well,
There you go, right? And you
Well,
just don't know.
there's a newer hypothesis now that people who are testing positive a second time after they go away is that the virus is actually going dormant and you're not having the viral
Or is
load.
it moving?
Or is it you're not having a high enough viral load that your body's attacked it enough for the test to actually detect at that time for cure, and that it's resurging so that, I mean, this is a huge topic just in general, but we're gonna start wrapping it up because it's about that time. No, you're
That's
good.
good.
No, that's a good thing to start thinking about, is that the cytokine storm, the bradykine storm, I mean, all those things we need to start looking at. But in the same token, you know, that is stuff we need to look at. We need an educated path forward in relation to what we got to do now, right?
So I want to make a quick point about this, because if you look at the Big Five conferences in football, 2 of them are not going to play this season, right? It's the Pac-12 and the Big Ten. Everybody has access to the same data, and in theory, they all have the same incentives and the same interests, but they've arrived at different conclusions. And they've never come out and said specifically, this is our reasoning, and the equation that they're using, how they're weighting the variables to arrive at different conclusions. You don't hear about it. You speculate, okay, these are the ones that make all the money, therefore they're going to play. But the ones that aren't playing, one of the things they talked about was they're worried about young men who are healthy when they get COVID having heart effects and maybe at a later date. But I don't know how compelling that evidence is. Other people have said, well, I don't know if it's the physiologic concerns. They're worried more, maybe it's going to be a lawsuit 10, 15, 20 years later when we find that out. It isn't that there's evidence right now that there's a problem with cardiovascular disease that may be looming. But the point being, highly informed people with all the resources necessary still can't come to agreed upon consensus and conclusions, and they're acting in different ways. So how can you expect the average individual walking around, especially when their source of information is the news media, to make informed opinions or have a consensus? I don't think you can. So one of the things I think we're trying to do here is say, how are we reasoning about this, and what do we think are reasonable things to be considering? And what we've concluded, as I understand it, is that masks make a lot of sense. And we also all kind of agree that this is something that should be shelter in place, maybe more for the elderly and those at risk. And the rest of us are going to have to accept the risk of living lives because there's so much other suffering that comes with this. I don't know if that's a good synopsis of what I think I've heard from the conversation, but my emphasis on that is it's very hard for the average person, or even a person that's highly informed,
Even the medical one.
yeah, even highly informed, to make a highly intelligent position without, Loctite information. And we rarely have it. And that's vexing. So I don't know, I feel like that's kind of where we are. But we do have some things we know. The things we know we should act on.
Mm-hmm.
That's what I would summarize from this. What would you say? Anything you'd summarize from what you're hearing?
No, I think you touched on it on a lot of really critical points. Just to sort of circle back around, we were having a discussion before this started about herd immunity, which is sort of what you touched on and what was sort of been discussed here, and that there's a population study about 92%. You said 55 and older were the majority of COVID.
And it's not a study; those are actually numbers.
Okay, 92% of the reported COVID cases are in the 55 and over population.
No, that died.
That died. So some data suggests that I've read that herd immunity, and we've had this discussion, it will arrive somewhere around 43% of the population being infected. If we know and understand, based on the census data in the United States of America, that like 35% of the population is 55 and older, if you sort of isolate them, and that leaves 66% of the population sort of down here, well, if we're on this pathway to herd immunity, if we can infect the lower population and get to herd immunity with those people that have a higher likelihood of surviving the illness, that sort of makes sense to like open up the economy and like get things back to like life.
You're gonna have a hard time convincing moms that it's gonna be perfectly safe to have your 12-year-old, 14-year-old, because those are my kids' age.
Yeah.
Okay, I mean that's going to be a little difficult, but and herd immunity is a very good topic to talk about. But I think we're going to need to talk about that next time because we're almost at the 60-minute mark now. So there's a lot of topics, but to conclude, I think you summarized it very well. Again, we know we touched on a lot of topics that are very controversial. We'd love to hear from our patient population, our population in general, what topics you would like to hear about from us, what topics you'd like to discuss in general, topics about COVID, and we'll be happy to do the research and do the numbers. I'd like to caution people just in general, just be careful about what you're posting online, what you're reading, and really look at and see where the data is coming from. Is there a bias associated with the data? Who takes advantage in relation to that data, just in general. And we're going to do our best to make sure that we're giving you actual numbers, actual facts that have no spin on it, and then talk about them as best we can. So thanks for joining us in this discussion, and we look forward to next time.